I'm Dr. Parikh. Nice to meet you all. I am currently the Washington, D.C. REI, and I am also kicking off the Houston clinic as well, and that will be my future home. I am joined here today with Dr. Awonuga, who is also one of our Kindbody REIs and is representing from Detroit. I want to go ahead and give him the opportunity to introduce himself.
Yes, good evening, everybody. Again, like Dr. Parikh had said, my name is Awoniyi Awonuga. I am the Detroit REI physician for Kindbody, and I'm also a Wayne State University faculty. I think that's all I'm going to say. Welcome, everybody, and thank you for joining us.
Great. So I wanted to just start off this chat just by introducing Kindbody and giving you all an idea of what Kindbody is and how it differs from your typical fertility clinic. We are a fertility clinic that is largely out there to ensure that individuals have access to care from all financial statuses, as well as mental statuses, as well as physical statuses. Our goal is to try to improve and, create a voice for all individuals with infertility or fertility needs through not only a location for you all to consider treatment and care, but also indirectly by working with your employers to try to see if they can provide you with benefits to access this care without the additional added burden of finances. So we are super excited to be a part of your fertility and family planning needs. Next slide. So what do we actually do? We do quite a bit. We not only provide fertility treatment, which includes fertility assessments, just basically wondering where you're at in your fertility profile of whether or not you're able to conceive, if there's any difficulties that you're facing. We provide both in-person as well as virtual consultations. We also provide egg freezing and IVF care. We go and provide a spectrum of different options, including donor egg, donor sperm, any sort of surrogacy needs, genetic testing for individuals who have family-related congenital or genetic issues, as well as providing a wide spectrum of mental and counseling support. This support is present for those individuals just desiring to improve their health and wellness, as well as nutrition, all the way to services just to get a little bit more information for those specifically looking for donor gametes, where they may be seeking additional services to help to assist them in conceiving. We as Kindbody are on a mission. We are largely looking to educate the population at hand about what fertility is, how it actually works, and what issues individuals face depending upon their age and also their GYN status, if they do have any sort of medical issues, and how that can impact their fertility care needs or future plans. It is really important for us to make sure that women and men today understand how their bodies work, how it functions, and how they can be proactive when it comes to ensuring that when they are ready to have a child, that everything is set up so that they are optimized to have a good outcome at the end of the day. So this is Fertility 101. It is going to be just a basic overview of how fertility works, and hopefully answer some of the basic questions or lack in information that you may have. And then if there's any additional questions you may have, please feel free to enter them into the chat or ask them at the end, and we would hopefully be able to reach them. And if not, we will make sure that your questions are answered at the end. Great. So Fertility 101, we are taught our entire lives how not to get pregnant, right? It's when we're really young, we have courses within school itself that educate us on how to not get pregnant or how to get on birth control to prevent pregnancy or, inadvertent pregnancies. And so really what's not taught is how to actually get pregnant. And so that's what this entire course is going to be about. So the biggest impact when it comes to fertility is going to be one's age. For women, age is quite impactful on an individual's fertility. For men, a little less so in the beginning. And then as they age over the age of 40, then age becomes also a factor when it comes to male reproductive health. For females, usually we'll say that the typical age that we tend to highlight is 35. Individuals over the age of 35 will have a higher risk of having miscarriages, will have a higher risk of having reduced ovarian quality as well as ovarian quantity. And these are the things that we want to sort of highlight in this talk today. So how does fertility work? We as women are born with a certain set number of eggs that our parents have given us and bestowed to us. And so by the time we reach our first period, we are typically down to about 300 to 400,000 eggs. And then every month where we're actually bleeding or not, when we have a cycle, we lose about 1,000 eggs. And so over time, that initial basket of eggs that we start off with sort of starts to kind of dwindle and reduce in both quantity and then also quality. So as I mentioned before, our typical age that we talk about is 35. This doesn't mean that before 35, you're fine, and after 35, it's a problem. This is just a rough average of an age where we see that egg quantity and quality typically declines around this time. For some individuals, it may be a few years before. For others, it may be a few years after. But the idea here is to make sure that the public at large is aware that around 35, maybe you should be asking yourself the question of, am I worried about my egg quantity or quality? Maybe I should get it checked out. Are there any concerns that I should know about off the get-go? And then for us to be able to make sure that lab-wise, through an ultrasound and looking at your ovaries, that egg-wise, things are looking appropriate for your age, or may not be concerning, where we can offer other options for intervention. This, again, doesn't just all of a sudden happen at age 35. This happens slowly over time. And so before age 35, we usually say the majority of our eggs are probably pretty good. And then after 35, we start to say the majority of your eggs may or may not be really good, and that we probably need to work on or discuss options in terms of either egg preservation, where we're just basically freezing your eggs and holding them steady at in one space and time, or to talk about conceiving sooner than you had intended to plan to, just as a way to hopefully get to your goal, which is to have a child. 1 out of every 10 women will experience what we call premature ovarian low reserve or ovarian failure, where they're under the age of 35, but yet they're having issues with having reduced egg count or egg quality. So as I've highlighted here, most of us are kind of worried about quantity. Do we have enough eggs around? Are they there? And there are tests that we can do to check for that. But really, it's both quality and quantity that we have to talk about. And unfortunately, at right now where science stands, we don't have a way to really measure quality other than to use your age and say, okay, well, if you're 25, chances are your quality is pretty good. But if you're 45, maybe your quality is not as great as when you once were 25. And so that's as much as we have to be able to tell you what the quality of your eggs are outside of labs and ultrasounds to monitor. Once we actually fertilize those eggs and turn them into embryos, that's when we as embryologists and infertility specialists can actually get an idea or a sense of how your egg quality is, and then subsequently offer you genetic testing to test whether or not those embryos are normal or not. And that's the best test or sense that we can get as to what your quality is outside of trying naturally to conceive. But the truth and the reality is that you are never too young to get tested, right? I've have patients who are 23, 22, and they find out that their ovarian reserve is actually not that great. And this is an opportunity for them to actually be proactive, be able to say, hey, do I think I'm going to conceive in the next 5 years? And if not, maybe I ought to think about freezing my eggs so as to make sure that when I am ready at 33 or 35 to conceive, that I have the best opportunity to conceive without any difficulty, and I don't look back and regret not doing things sooner. And that's the whole point of our fertility assessments from the from Kindbody standpoint. We just want to make sure women know where they stand, that they have the opportunity to protect their egg quantity and quality for the future, and then hopefully lend a helping hand if things are becoming difficult. So just to kind of go over a woman's menstrual cycle, I get asked a lot of times by my patients, like, when's the best time to try? Do we just try once, or do we try multiple times? Do we have sex every day? And so the truth of the matter is that everyone ovulates at a different time. Some people ovulate at 12 days and they're very regular at every 12 days. Others ovulate somewhere between day 10 and day 14. Some people ovulate 16 to 18 or 20. And so really, when you're having regular menstrual cycles, meaning every 28 or every 30 days, you typically ovulate somewhere between that 10th to 14th day of your menstrual cycle. And during that time, one or sometimes more, maybe two, eggs from your ovaries actually then become mature and then undergo the process of ovulating or leaving the ovary to then make its trek down the fallopian tube and wait for it to be introduced to a sperm. Naturally speaking, once that ovulation process occurs, the egg will then fertilize within 24 to 48 hours of being ovulated, and then either you conceive or you don't conceive. Sperm, on the other hand, can sort of hang around inside the uterus for somewhere between 3 and 5 days. So it's not necessary that you have to have intercourse every day in order to conceive, but we typically recommend individuals try to improve or increase the number of times they're having intercourse around that day 10 to 14, so as to improve their chances of conceiving if they have a 28-day cycle. If their cycles are a little bit longer, then the ovulation day is going to probably be pushed back a little bit more. And then the recommendation is to kind of try to conceive around the day of your ovulation. And generally speaking, we usually recommend somewhere between every other day or every day around the time of ovulation. A lot of times patients also ask, what factors impact fertility? Like, how can I improve my ability to have a good egg, or a good IVF cycle? And the truth is that it's really a thing. It's a really something that we have to do on a daily basis, right? It's not something that we can just do for a month or two and try to improve ourselves. But really, the fact is that diet and exercise and lifestyle is going to be your number one impact on fertility. So making sure that you're eating a low carb, high protein diet. Typically, infertility specialists will recommend the Mediterranean diet, which has been shown scientifically to actually impact egg health and sperm health. And so, trying to have fresh fruits, fresh vegetables, lean proteins is really important here. Somewhere between 3 to 4 days of exercise in a week is what's recommended when it comes to exercise. Roughly about 20 to 30 minutes is really all that you really need. And then, other things that impact fertility health is going to be your genetic history. What is it that your parents gave you? And then also your mental health. How much stress do you have? Are you super stressed during this time? Or are you engaging in things that allow you to relax and help you to reduce that stress load, which is definitely going to impact your overall cycle quality and egg health and sperm health. One of the most common things is when a patient asks, "Am I infertile?" Right? And the definition for infertility kind of varies depending upon your age. Generally speaking, physicians will say if you're younger than 35, then you should wait at least a year of having regular intercourse, regular menstrual cycles. And then if you're unable to conceive in that time, that's considered infertility. Over the age of 35, we say 6 months. If you've been trying for 6 months and unable to conceive, we really want you seeing a fertility specialist a little bit earlier, because we don't want you to wait the full spectrum of a year, because that only delays your chances of conceiving even further. And so we like to see patients over the age of 35 sooner, so as to try to get treatment on board faster and hopefully get them pregnant at a younger age with higher egg quality. And so generally the rough average is that 1 out of 8 couples will experience some form of infertility, whether it be female factor or male factor, where 1/3 of cases out of those individuals will be some form of male factor infertility, whether it be that the sperm don't move well, or that there's just not an enough amount of sperm available, or whether or not there's sperm at all. So I guess overall, my desire is to ensure that everyone here understands that there's no special way of improving one's fertility health. There's no magic pill or magic supplement regimen or exercise regimen, but that overall trying to improve your health and lifestyle, as well as be proactive in checking out your fertility and ovarian reserve or sperm status, is really important and allows you to have power over what next steps you take in order to preserve your fertility for the future if there is an issue. I'm going to take this moment to turn it over to Dr. Awonuga, who's going to talk to you a little bit about the general workup that we do with Kindbody.
Thank you very much, Dr. Parikh. So I'm going to take over here now to talk about how we work up patients who come to us for fertility issues. It is actually very, very important that you have a consultation with a fertility specialist. Why do I say fertility specialist? Because we want to take advantage of the latest information in the field, and that's very important to see a fertility specialist. And during that consultation, your medical history will be discussed. It's very important to initially determine what the goal of the consultation is, whether in fact is infertility or other problems associated with polycystic ovary syndrome, for example, since we are now in the polycystic ovary syndrome week. What's also important is to have a gynecological history taken. Like Dr. Parikh had said, it's good to determine what the kind of what type of cycles you have. As a matter of fact, from the history, it can be possible to determine whether a woman is ovulating or not. It's also essential to take your past medical history, your past surgical history, because getting pregnant, you want to make sure that your health is perfect. You don't want to get pregnant and then we find that there is issues that we could have addressed before you get pregnant and not have addressed it. So it's essential that is a good medical history be taken. It's also essential that we take your past past surgical history, because there are previous surgical history that can impact your fertility, and therefore we need to know this. For example, some people have had a previous surgery on their ovaries that will decrease their ovarian reserve, so it's essential to know that. It's also essential to know whether there has been a history of sexually transmitted infection, because again, such infections can impact fertility. For example, it can block the fallopian tube, which is the tubes that carries the egg after ovulation to the uterus. And the tube is also essential because that's where sperm and the egg meet, get fertilized before it travels to the before the embryos travel into your uterus. If the plan is for fertility, for example, it's essential to know your family planning goals, to know, for example, how many babies you want to have, when you want to actually start a family. Those are very, very essential. Now, given that people are different, especially when it relates to polycystic ovary syndrome, it's essential to see a reproductive endocrinology and infertility specialist to actually put in a personalized plan and determine what the next steps should be for you to follow moving forward. Next slide, please. So what are the investigations we do? We do blood work to start with and then an ultrasound. The blood work, I divide it into two. One, to make sure that your health is excellent. Like I said before, you don't want to get pregnant and you find some issues with your health. Secondly, we need to do blood work specific to your goal in terms of fertility. That's number one. And two, to determine whether there are other problems that we need to address. And we also need to determine whether you have some menstrual issues, because if you're not trying to get pregnant, we still need to sort out any menstrual issues that you have. Then we go ahead to do an ultrasound. The ultrasound is done through the vagina because the ovaries are right on top of the vagina, and therefore, when an ultrasound to the vagina, you'll be able to see the ovaries very well. And what we do is to count the number of follicles. These are small, tiny cysts that contain the eggs. And every month, women recruit about 10 to 20 of those follicles every month. And the number you recruit determines how well your ovarian reserve is. And I'm going to talk more about that as we go along. We also do blood tests. We measure the AMH. Anti-malarial hormone, that's AMH, is only part of the blood test we do, but we do far more. Next slide, please. Next slide, please. Okay, so when we do blood tests, like I mentioned, we measure your AMH. Normal AMH is about 1 to 6, and if it's between 1 to 6, it's regarded as normal, but it may be higher. especially in patients with polycystic ovary syndrome, and it also may be lower, especially in older women or women with poor ovarian reserve. And that actually happens with age. As you get older, the ovarian reserve decreases, and by the time you get to 40, 45, it's actually very, very low. And that's when you are likely to have values that are less than 1. Just for me to also mention, the anti-Mullerian hormone is produced by cells that surrounds the follicles. We call them granulosa cells. And patients with polycystic ovary syndrome, for example, because they recruit more eggs, they have a much higher level of polycystic ovary syndrome, and their levels can be much, much higher than 6. In terms of anti-follicle count, like I mentioned, women will recruit about 10 to 20 follicles every cycle. Polycystic ovary syndrome women recruit more, who will reduce ovarian reserve recruit less. And we use anti-follicle count to determine how women will respond to the drugs that we give to make them ovulate. And if they're having an IVF cycle, for example, we actually give us an idea how many of those eggs that we're likely to collect from them. It is important to note that the anti-follicle count varies from month to month, but variation is actually not that large. It's about, could be slightly less than 5 or more than 5 of the actual anti-follicle count. Next slide, please. So what options do you have in terms of treatment? Dr. Parikh is actually, Parikh has mentioned that earlier. Those are the options that you have. You can freeze your egg, for example, especially if you do not have a partner yet. You can freeze your eggs for future use, or you can freeze embryos if you do have a partner. As a matter of fact, reproductive endocrinologists have more experience with embryo freezing, but we are also very good now with egg freezing, so you can take advantage of either of those. And next is your treatment. Treatment varies according to depending on your goal. But if you're ready to get pregnant now, your treatment can vary from just giving you medication for you to go and have sex at the appropriate time. And if you want to actually get pregnant quicker, you can move on to intrauterine insemination or IVF. And at Kindbody too, you have also the opportunity for a third-party treatment. If you don't, for example, cannot produce enough eggs, or you are older, you can use egg donation. If your partner does not have sperm, you can also use sperm donation. Obviously, if you don't have a uterus, you can also use a gestational carrier. Next slide, please. So, what is egg freezing? This is used to use if you don't have a partner, or that you want to commit yourself to now, or you don't have a partner at all, you can use egg freezing. And egg freezing is the process of extracting eggs from the ovaries and freezing them for later use. Next slide, please. So, we should consider egg freezing. So, any woman can actually freeze her eggs, depending on the circumstances she's faced with. But these are the 4 questions that you need to ask yourself before you consider egg freezing. One is how old you are. This is important because how many eggs we collect depend on the age of a woman. And other factors that are important is whether, in fact, there has been history of ovarian surgery, in which case you are less likely to get eggs, or if you have polycystic ovary syndrome, you are more likely to actually get more. What's also important is how many children you plan to have for your own ideal family. How many eggs you need to be retrieved to complete your family would depend on how many eggs we collect in any one time that you have IVF. Bear in mind, depending on how many eggs we collect and how many kids you plan to have in the future, you may have to have more than one cycle of IVF to actually reach your goal. And how old you will be when you have your first child is also very important. Bear in mind that as women get older, medical problems start to rear their ugly head. So you need to actually decide when is best for you to have your first child. And apart from the fact that the number of eggs that we collect will start getting lower as women age, so those medical problems as women age. Things like diabetes, hypertension, hyperlipidemia, especially in patients with polycystic ovary, starts to tear their ugly head. So I will always advise not to leave childbearing for too late. And the same goes for how old you plan to be before you have your last child. Next slide, please. So how does egg freezing work? Like as we mentioned, depending on age, women recruit about 10 to 20 follicles each month. And when we stimulate to make women produce eggs, our aim is to collect about 10 to 20 eggs every month. Every cycle of IVF that women go through. Patients can have less depending on their age and depending on how many follicles are recruited every month. As I mentioned earlier, patients with polycystic ovary syndrome will recruit far more, and patients that are older or have had previous ovarian surgery will recruit less. Next slide, please. So with fertility care, most REI are optimistic, and we are very optimistic at Kindbody. During egg freezing and IVF, for example, we give you hormones. These are hormones that are similar to what women produce every month to make them produce eggs. It's just that we give them more of those hormones. And those hormones are released from the brain, and they work on the ovaries to make them grow. We give those hormones injections every day to recruit more, the eggs and make them mature. At the start of the cycle, the eggs are not mature, and these injections are necessary to actually make them grow to the mature state before we collect them. Next slide, please. So the hormones we administer injection, we usually, like I mentioned earlier, these injections have to be taken daily. It takes about 10 days on the average for those eggs to reach maturity before we collect them, and we monitor the progress of the follicle development. Follicles contains eggs during the 10 days, and usually patients will need to come to the clinic about every other day or towards the end of the stimulation every other day to monitor how they respond to treatment before we determine when the follicles are mature and plan how to collect the eggs. Next slide, please. So it takes about 10 to 14 days for the eggs to mature. And as I mentioned earlier, this includes hormonal injection that makes them mature. When they are mature, we have to give them another injection, which is HCG, to actually start the process of ovulation. The eggs are usually attached to the wall of the follicles, but they need to be released so that we can collect them. As a matter of fact, they need to be released for ovulation. And usually what we do is get there before ovulation itself. Ovulation starts so that the eggs are not released so that we can collect them. And we collect them by ultrasound as we go through ultrasound guidance, as I will allude to in the next slide. So how do we retrieve the egg? The egg and the ovaries are actually on top of the vagina, and therefore the best way to retrieve them is to go to the vagina with ultrasound probe. As this actually is a very difficult procedure. It takes only about 10 to 15 minutes for the procedure to be completed, and we usually give a light anesthetic to do this. Next slide, please. So when we've collected the eggs, depending on what the plan is, whether the plan is for a woman to freeze her eggs, or whether in fact she wants to move on to create embryos. So if the aim is freezing eggs, what we do is we will, after we collect them, is that we will freeze them immediately for future use, and we freeze them in liquid nitrogen, and those eggs can be frozen for as long as possible. You will freeze eggs if you are not committed to if you don't have a male partner, or if you are not committed to a sperm source. Therefore, you don't actually have to freeze embryos. If you are single, or you're not committed to a sperm source, then it's better to actually freeze embryos. And by the way, this will be the best way to go if you have a partner, because like I mentioned earlier, we've been freezing eggs for quite a long time compared to freezing embryos for quite a long time. Although now we are also very good with freezing eggs, and it's been shown that there's no difference in pregnancy rate, whether you freeze eggs and you use it later on, or you freeze embryos and you use it later on. Whether you freeze eggs or not, the chance of getting pregnant is the same. Next slide, please. So what comes next? After you've collected your eggs or the embryos, the eggs will be stored in a long long storage facility, and you can come back and use your eggs at any time. But again, like I mentioned earlier, you have to consider age as an important factor in determining when you want to get when you should actually use them. Our hope is to get you pregnant naturally in the future. But again, freezing your eggs or your embryos is like an insurance policy. If you can get pregnant on your own, there's actually no need to come and spend money to use the ones that are frozen. But if for whatever reason that is not possible, then you can use your eggs or your embryos in the future. And like I said earlier, these eggs and embryos can be frozen for as long as possible, and freezing does not damage eggs and also does not damage embryos, and we know that for a fact. Next slide, please. So, what is IVF and how does it work? Again, this is a process. The process is the same egg as, or this process is the same for egg and for embryo freezing up until egg retrieval. So whether you're freezing eggs or freezing embryos, we still have to collect our eggs. And what is done after that depends on your plan, whether you want to freeze your eggs or whether you want to freeze you want to move to fertilizing those eggs to create embryos. And to do that, we collect your partner's sperm and we put the sperm and the egg together to fertilize the eggs. And once the embryos are created, you can, if you are going to get pregnant straight away, we can transfer those embryos to your uterus for you to get pregnant. And we're very good at that now. Even without testing the embryos, you have about a 50% chance of getting pregnant. If you can afford to test them for us to determine whether they are normal or not, your pregnancy rate goes to about 60 to 70%. That's if you want to actually have a fresh transfer. Next slide, please. So, what are the paths to parenthood? So again, this depends on what you have in mind to start with. There are various treatment options. Obviously, the best thing is for you to get pregnant on your own. But if within 6 months you are not pregnant, if you are more than 35, or within a year, if you're less than 34 and you're not pregnant, then it's better to actually seek treatment. And the earlier you seek treatment, the better, depending on how you are. And we can offer you from very simple treatment to the most sophisticated treatment. And as you move from simple treatment to the most sophisticated, your chance of getting pregnant will rise. So the simplest treatment you can have is to give you medication to ensure that you produce an egg or eggs, and then ask you to go and have intercourse. That is simplest, but is associated with the lowest pregnancy rate. And you can try that to start with, or if you want to move to a more successful treatment, you can have what we call intrauterine insemination. And insemination, you can use your partner's sperm, or you can use donor sperm if needed. And that will give you a better pregnancy rate than if you were to go and have timed intercourse, medication at timed intercourse. IVF gives you a better pregnancy rate than intrauterine insemination. Again, you can use donor sperm if needed. If one does not have a partner, donor sperm is available for you to use. And whether you use donor sperm or partner sperm, the pregnancy rate is the same. Now, for IVF, you can test the embryo if you want. It gives you a better chance of getting pregnant, like I mentioned earlier. Now, if for whatever reason you don't produce eggs anymore, either because one is older or the ovaries have been removed for whatever reason, or you've tried with your own eggs, you tried to have IVF, and after stimulation, eggs are not retrieved, you can use donor eggs. just as you can use donor sperm if you don't have a partner or your partner does not produce sperm in his does not have sperm, I beg your pardon, in his ejaculate, you can use donor sperm. Obviously, you can also use gestational carrier if you, for whatever reason, either because you've had your uterus removed, for whatever reason, you can actually have gestational, you can use gestational carrier, and Kindbody can offer you any of these treatments that I've mentioned above. Any of the treatment that I've mentioned. Next slide, please. I think it's over to you, right? I didn't finish here, yes?
Yes, I could take over.
Yeah.
And so really, I think what Dr. Awonuga was actually saying here was that in the process of considering either egg freezing or IVF with all of the detailed steps that he's described so far, the main notion here is that knowledge is power, right? The more that we know about you, the more that we have available, the more power you have to make decisions and options and choices in the future regarding your fertility care. Next slide. So I'm going to transition here over to PCOS, as I know that there have been a lot of questions in the chat box regarding polycystic ovarian syndrome, otherwise known as PCOS. I'm going to start off by just generally going over a brief definition of PCOS. Next slide. So what is PCOS? In countries that are of good nutritional status, such as the United States, we've got obesity that tends to be on the higher side. And so in the United States, PCOS, 1 in 10 women will have it. And PCOS is a condition that can either be genetic, where you're born with it because your mom had it, your grandmother had it, your sisters have it, or it could be something that is acquired through diet and lifestyle. And so generally speaking, women who have PCOS are defined as having polycystic ovarian syndrome when they meet 2 of 3 criteria. And those criteria are irregular menses, meaning that your menstrual cycles do not occur on a monthly basis. They happen every 40, 50, 60 days at a time, sometimes every 30 days for a couple months, and then it goes back to another 60 days. That's considered irregular cycling, or one of the criteria to say that you have PCOS. The second criteria is something we call hyperandrogenism, or excess levels of male hormones such as testosterone. That usually is presented in ways of having increased hair growth, whether it be around the chin, around the midline of the abdomen, arm hair that can be quite thick in nature, or leg hair, and then also acne. These are sort of secondary, presentations of having high levels of testosterone, where we would be concerned with someone having PCOS. And the third is polycystic appearing ovaries, or ovaries that on ultrasound have greater than 12 follicles per ovary. And so 24 follicles total. And so in those individuals, we would say that if you have 2 out of these 3 presentations, that you would then be considered to have PCOS. It is thought that individuals with PCOS tend to have characteristics where they are usually obese. Usually, we can have individuals who are not obese that have PCOS as well, but that's not the large majority. Individuals who have insulin sensitivity or insensitivity, meaning that their insulin levels are just not being sensed as easily, as their metabolism is slower than the typical. And so these individuals can present with PCOS. And, these characteristics are not what we use as criteria, but then can often be seen in individuals who have PCOS. Next slide. So the polycystic appearing ovaries, you can see it here, whereas the picture on your left shows 3 or 4 cysts inside of an ovary. It looks like 3 there. Whereas the one on your right, you can see multiple small follicles, or I like to call them chocolate chip cookies. So they're the chocolate chips within the cookie. There's multiple chocolate chips that are present where there's clearly greater than 12, where the ovary sort of doesn't get the stimulation or the signal required or needed to give the brain the signal to ovulate. And so because there's a disconnect in the messaging system from the ovary to the brain and the brain to the ovary, these follicles will never then become large and nice and mature like you see on the left. They'll remain small and tiny like you see on the right. And then there's not a mature egg that forms to then ovulate and then have a menstrual cycle to follow. Next slide. So PCOS affects fertility by preventing ovulation. So there's a lot of little small eggs. It's kind of like a traffic jam. I usually tell my patients there's a lot of eggs. They're there. They're just not getting the message to become large and mature to be able to ovulate off and then subsequently attempt to conceive with. The eggs stay nice and stay small and immature, and therefore then don't lead to pregnancy because they never ovulate or leave the ovary to enter the uterus for it to have a chance to meet a sperm and fertilize. Next slide. Do all women with PCOS need fertility treatment to conceive? No. Even women who have infrequent ovulation, meaning you're not having regular menstrual cycles, will still conceive. And that's because you still occasionally do ovulate. And when you do ovulate, as long as you're having rather regular intercourse, you should at some point conceive. It's those individuals who go 6, 7, 8 months without ovulating that then have a tendency to have a difficult time conceiving. But with our help, we can provide you medications or treatment or management plans, whether that be changing your nutrition, changing your exercise habits, helping you to lose weight, helping to reduce the overall estrogen levels that are floating around in PCOS environment, to help to allow for regular ovulation to occur and to help you conceive. And the medications will help to allow for that ovulation to occur and for you to conceive, still doing time intercourse or the options that Dr. Awonuga nicely characterized of IUI and IVF as alternatives. Next slide. So typically women who have PCOS, I'll tell them, okay, if you haven't had a menstrual cycle in a while, then we'll give you medication, something like progesterone, to help you bring on a period. And then once your period hits, that's an actual fake period. It's something that we've given you hormones to induce. And so after that, we give you medications to help you form that nice mature egg. And then you would use ovulation predictor kits at home to see whether or not those medications are helping you to ovulate. So you may have heard of Clomid or letrozole, also known as Femara. These medications are often used by your OBGYN or your infertility specialist to help allow for your ovary to create that one mature egg, or maybe more than one mature egg, to allow you to conceive once you ovulate. And so ovulation predictor kits can help you to see whether or not that medication treatment is actually working, because they then will then turn positive in the midst of your cycle. And then you can try to have intercourse somewhere around there to help improve the chances of conceiving. Now, in women with PCOS, sorry, can you go back one slide? So in women with PCOS, because the cycles are not regular, that ovulation predictor kit may not actually turn positive and may just be like a almost positive for a long time, because that signal to actually ovulate is not actually occurring. Next slide, sorry. So some of the fertility treatments, like I mentioned, is Femara or letrozole, Clomid or clomiphene. We use these medications to help increase the number of eggs that actually become mature. We do that in a very sort of controlled environment, whereas to not create more than 2 or 3 eggs at a time, because obviously we don't want multiple pregnancies. More than two at least, triplets, quadruplets, et cetera, higher order multiples. And so once we give these medications, we often will follow them with an ultrasound to ensure how did the individual who's taking the medications respond to the medications. Do we see 1, 2, or 3 eggs, or are there more than that where we probably shouldn't actually move forward with intercourse and trying to conceive in that cycle, and we should back off on the dose of the medication? Once we see the 2 or 3 eggs present, we would then offer the option of doing an ovulation trigger. That's a medication that you will inject on your own at home at a certain time that we tell you to. And that medication is used to help you to ovulate. Once that medication is administered, the body undergoes the process of ovulation, and then we can counsel you as to whether or not you desire to do time intercourse or potentially do intrauterine insemination, where we prep and place the sperm inside the uterus for you so as to increase the chances of conceiving even higher. Other additional treatments can also include supplements that can be found either over the counter or / be prescribed. And those include myoinositol, which has been thought to improve one's metabolism and help to improve the quality of eggs that are being ovulated. And then metformin, which is thought to help to reduce the insulin insensitivity that an individual may have and help to improve metabolism and therefore allow for ovulation to occur in an improved manner. Using all of these things, if we are unable to sort of stimulate your eggs in a controlled manner that's appropriate, meaning that maybe you over respond and we can't use these treatment options, or maybe using these treatment options, you're not responding at all in those settings, or if you've used them and you've responded appropriately but still not conceived, we would then consider treatment options like intrauterine insemination or IVF to help assist you to conceive. The truth of the matter is that most individuals with PCOS through IVF can actually have a very high likelihood of conceiving. Typically, individuals with PCOS will have some effect of the PCOS to ovarian egg quality. And so oftentimes we see these individuals who will be able to have 20, 30, 40 eggs retrieved, but the quality of those eggs are just not as great as an individual without PCOS. And so we always like to caution individuals that even though your egg quantity is high, the quality of your eggs may not be as great. And so we just need to kind of keep that in mind when we're talking about treatment options. Next slide.
Yes. So can I take over now? Yes?
Yeah. Yes, please.
So we're going to quickly talk about the non-fertility effects of polycystic ovary syndrome. Now, polycystic ovary syndrome is actually mainly due to high male hormones, testosterone. Now, both men and women produce testosterone. In women, the testosterone is from the ovaries, and there's also a little bit of male hormones from the adrenal glands as well, and they cause most of the problems that women have with polycystic ovary syndrome. So, what are these non-fertility effects? One is hirsutism, abnormal hair growth, and acne. Now, not all polycystic ovary syndrome will have this, but this can be a nuisance for some patients with polycystic ovaries, and they actually need to have it treated, and I will allude to that as I go on. Also, polycystic ovary syndrome, women, their muscles, their tissues are resistant to insulin, and therefore they have what we call hyperinsulinemia. So a high level of insulin because their tissues are resistant, and therefore they are prone not only to diabetes, but even before you get to the stage of diabetes, they can have what we call insulin resistant, and that can also cycle back to make them produce more male hormones in their ovaries. So apart from insulin resistant, they can have pre-diabetic and end-stage diabetes. And again, this needs to actually be taken care of. Next is high blood pressure. They are also prone to high blood pressure. a good number of them, I would say about half of them are obese, but not necessarily. There are PCO women that are not obese. You actually have lean PCOS women also. You cannot, so one cannot say because a woman is obese, then that she has polycystic ovary syndrome. Again, they are prone to endometrial cancer, depression, and anxiety. But how do we manage these patients? Asceticism and acne is something that could be a nuisance, and the simplest treatment is to use the combined hormone contraceptive pill. And the reason why hormone contraceptive pill works is that it can mop up the a lot of can feedback to the organ in the brain called the pituitary that is supposed to secrete the hormones that make women produce high estrogen, high luteinizing hormone that makes them produce the testosterone. And the next thing that it does is that it can also increase what we call serum hormone binding globulin, which is the hormones that mop up the androgen in the circulation. Next, you can use spironolactone. This is a drug that inhibits or reduces estrogen androgen production, but you can't use that because it can damage the baby if a woman gets pregnant whilst taking this medication. Therefore, we always advise that when you use spironolactone to reduce hair growth or acne, that you combine it with oral contraceptive pills. Alternatively, you can use physical means, laser, for example, for hair removal, or electrolysis to actually reduce excessive hair growth. So as for diabetes, high blood pressure, and excessive weight gain, you can use low glycemic index food, exercise. Metformin is a drug that we use, is an insulin sensitizer. Not only can it decrease the excess insulin that PCOS women produce, but it can also be used to treat high glucose level as you get in diabetes. So all this intervention can improve fertility also, and can allow a woman to get spontaneous ovulation. And if they have spontaneous ovulation, they can get pregnant on their own. And if there's no spontaneous ovulation, you can stimulate them with clomine or letrozole, as Dr. Parikh has mentioned, to make them ovulate and therefore allow them to get pregnant. Anxiety and depression are also very important. And in polycystic ovary syndrome, there are support groups that help with this. And also there are counselors that can help counsel patients with anxiety and depression, and therefore improve their outlook and decrease these complications. Exercise is very important also, and that may also lower the anxiety level and help with depression as well. Next slide, please. So the diet and lifestyle is very important. Like Dr. Parikh mentioned, this is a lifelong measure to try and improve the women's health, and also improve their chances of getting pregnant, and also can help to lower the sequelae of polycystic ovary syndrome. As far as the treatment plan is concerned for polycystic ovary syndrome, it's important to identify the root causes of the condition. I said all the conditions that can cause PCOS will act through increasing the male hormones that women produce. And we use the term hyperandrogenism or hyperandrogenemia for that. Now, polycystic ovary syndrome also is associated with low-grade inflammation. So anti-inflammatory diet will help, and they can also optimize gut health in these women and help in terms of preventing them from having from gaining too much weight. Obviously, the diet, the type of diet is essential for that as well, and we advocate for blood sugar balance, for metabolic health, and also for hormone balance. Movement, was exercise for healthy hormones, and blood sugar is very, very important in lifestyle and the diet that people use to actually combat the all the after effects of polycystic ovary syndrome. Stress management, good quality sleep for metabolic health are also very, very important. Next slide, please. So these are you can see in the picture here, these examples of all the different kind of food that are essential for women to take to improve their health. I can see green stuff, good quality fat, especially those ones that contain omega-3, good quality protein with a focus on fish and seafood. Probiotic foods are very important. Herbs and spices, turmeric, ginger, green tea, all the gamut. And I'm sure we all know this. You eat right, then you gain the benefits. Then the benefits of all these substances, as well as reduce toxicity from all the fatty food, excessive fatty food or sugar food that can actually damage women's health. Next slide, please. So the best diet for PCOS, blood sugar balancing diet, good quality protein with every meal that women take, healthy fats, all forms of fats, olives, avocados, seeds, nuts, and fish. Animal fats, also very essential. And it's also good to actually eat food with a lot of fiber to help move one's bowel as addition to improving one's health. Now, it is essential to eat at consistent times, at least 3 times a day, and also to avoid blood sugar spikes and crashes. And it's also essential to avoid excessive dieting or fasting, and because that is also may damage one's health. So make sure that you eat 3 times a day and avoid blood sugary spikes as well as crashes. Next slide, please. So the best diet for PCOS, to summarize, avoid sugar or sugary food, dairy, if not tolerated, gluten, very essential too, but if not tolerated, avoid too much excessive alcohol, refined flours, you should avoid, so that's also refined oils, very essential to avoid. Okay, next slide, please.
Dr. Awonuga, I'm going to take over here.
Yeah, okay.
So the best diet for PCOS here is really just to make sure that you're eating healthy, natural food items that are not processed, that are not fried. The biggest issue with PCOS is weight gain, which is thought to increase fat content, and fat produces estrogen. Estrogen then negatively inhibits your ability to ovulate regularly. So all of a sudden, if you start losing the weight, you lose the estrogen that's floating around, and that negative impact goes away and you start ovulating regularly. That's if the PCOS is due to a lifestyle issue of being overweight or with a poor diet. Typically speaking, PCOS individuals should avoid gluten and dairy whenever it is not tolerated by the body, as there could be negative impacts of the processing of those products by the body, and that could affect infertility. Everyone with PCOS should be on a low carb, high protein diet to help to improve weight loss goals. Next slide. So all in all, you have options. Fertility treatment can include anywhere from ovulation induction, where we give you medications to help improve your chances of creating a mature egg. We then kind of combine that with timed intercourse, or IUI, to help you conceive. Or we can go the route of doing IVF, where we actually remove the eggs from the ovaries and fertilize them and freeze them in the external setting. And then in addition to that, nutritional improvements, as well as counseling and making sure you're up to date with all your GYN care, is all very important when it comes to fertility treatment with individuals with PCOS. Next slide. So I hope you all enjoyed this talk, and that something stuck in terms of learning something new, allowing yourself to ask some questions that you may have not asked yourself before. If at all this was helpful and you're wanting additional help or resources, at Kindbody, we always have open doors. We're always known for our yellow signs. We're located all across the country. Our clinics are ever growing, and we would love to be a part of your care, or at least help to advise you as you're searching for the right provider for you. Dr. Awonuga and I see patients in the Detroit area for him, and then Houston and DC for me, but we have Kindbody providers all throughout the country. You can visit our website, where you can find the locations where we're located to find a clinic near you. Your insurance company would also be able to offer you who the provider of care is best for you with your coverage needs as well. Next slide. So the code that we had all promised you is PCOS 22. That's a code that can give you $100 off just an assessment if you're desiring one through Kindbody. It does offer a $500 off discount if you're looking to egg freeze or undergo an IVF cycle, if you have a partner of choice or a donor of choice in mind, and then $200 off in the IUI cycle, and that is good through September 30th. And so we would encourage you to go online at kindbody.com to schedule an appointment. You would need to create a portal, and then you would then subsequently schedule an appointment and talk to us about your reproductive desires and needs.
Thank you, Dr. Parikh. And we're at time here. If we didn't get to your question in the chat, please send it over via our Instagram, and that's at Kindbody, or you can email us at navigator@kindbody.com and ask us your question, and we'll be sure to get that answered for you. Thank you to everyone who joined us.